My name is Peter Collins. I'm Professor of Clinical Cardiology at Imperial College and the Royal Brompton Hospital in London. My talk was on the guidelines for chronic stable angina, and rather than going through the guidelines in detail, I've picked out a number of issues that I think are important on how best to choose anti-anginal drugs for our patients. And not just to look at first-line and second-line therapy, but actually to try and look at the patient characteristics, comorbidities, which will result in a better choice of anti-anginal therapy. None of the anti-anginal therapies show any benefit on mortality, but they are all effective anti-anginal agents. And I've emphasized really trying to look at heart rate and blood pressure and make better decisions as to which drugs we should use. Clearly, if patients have low heart rate and low systolic blood pressure, beta blockers and calcium channel blockers are going to further further impair that and may result in side effects which lead to withdrawal of the drugs. So then the second-line therapies, we have a lot of randomized clinical trial data in those therapies, and I concentrated particularly on ranolazine, which is an excellent anti-anginal, which has a database of just under 10,000 patients, randomized clinical trials, which show that it's a highly effective anti-anginal therapy in a broad group of patients. Diabetic patients, patients after acute coronary syndrome, patients with chronic stable angina, who are already on established therapy. And I put forward a rationale as to where that drug could be used in a large number of patients, patients with microvascular angina, patients who are diabetic, patients who have other comorbidities that don't allow other drugs to be started. I think that I certainly am very pleased to have this drug as a new part of the armamentarium with which to treat our patients with chronic stable angina. The other aspect of the talk that I concentrated on was the discordance between physicians' perception of how they're managing their patients and the patient's perception themselves. There's often a great discordance between what we think we're doing in patients and what the patients are actually responding with regard to angina control. And then put forward a very nice new methodology, if you like, with which to monitor patients. John Cam and Athanasios Manolis have published a recent paper showing a new star chart for angina monitoring, and I think that is under development and will make a big difference in terms of the way that we actually manage our patients with angina. So in balance, we have about 30% of patients are coming back to us after revascularization with angina. We have a large number of drugs with which to manage these patients, and we also have the new anti-anginal ranolazine, which I think has made a very large difference in the way that we can effectively manage our patients with chronic stable angina.